So this will be a 45-minute chat with Vanessa to learn about her progress in lung cancer research. If you do have questions, please drop them into the chat either directly to me or to everyone, probably best to me, and then I will try my best to thread them into our conversation as we move throughout the call today. Give me a second, I'm just adding a couple other people in. All right, so thank you, Vanessa. I'd just like to introduce you now. So for those that don't know Vanessa, she's now in her second year of a 3-year grant with Cure Cancer. Vanessa's grant is generously funded by the Denton Family Trust for the second year. Vanessa is based at St Vincent's Hospital in Sydney and also the Garvan Institute of Medical Research. Vanessa is a medical oncologist and a postdoctoral researcher. She divides her time equally between treating patients with head, neck and lung cancer and conducting research at the Garvan. Venessa is also a member of the Garvan Wiseman Centre for Cellular Genomics, try saying that quickly, and we're very privileged to have you here today. So welcome, Vanessa.
Thanks a lot, Nikki.
So, I mean, we've known each other for a few years now, but for those that have never met you before, can you give me a bit of background on why you started out in cancer research?
Yeah, so during my medical oncology training, which was a long time ago now, it was even obvious back then that the genetics of cancer was going to become really important, not only for research, but for treatment and management of patients. And so I really felt that getting some extra education in translational genetics was going to really be important for me as an oncologist. So for my 3rd year of training, I started a PhD here at the Garvan Institute, and I was working with one of the big genomics groups here at the time, the APGI, which is the pancreas group. And I spent my time there looking at sort of genetically targeted therapies in pancreas cancer, looking at sort of mouse models and cellular models of cancer. And then after my PhD finished, moved into the lung cancer space when I started my postdoc into a much more genomics focused laboratory. So really looking at the genetics of cancer, how the genetics prescribes how cancer behaves, and then moved into the cellular sequencing lab, where we are now using some really cutting edge genomics and genetics techniques to not only appreciate the genetics of cancer as a whole, but actually piecing together the different cell types that make up a cancerous mass. So the cancer cells, the non-cancer cells, the immune cells, we can now look at the genetics of those cells separately. And so that's sort of a brief story of my journey so far.
You've mentioned the word genomics or genomics, depending where you come from, a couple of times. Can you just explain in a bit more detail what that is for people that aren't familiar with the term?
So in any cell, we have DNA, and DNA is then sort of transcribed into proteins, and then proteins are what govern how cells behave and how cells undertake any of their normal cellular functions. And we know that looking into the DNA, but also then that journey from DNA to protein is important in the management of many diseases, cancer being one of them. And genomics covers the study of these processes from DNA to protein. So it's kind of like an overarching term and can look at things like DNA, RNA, protein, and other things.
Okay. And you're a bit of a mixed role here. So you do lab work as well as patient work. Can you explain to the audience why you do that and how important it is to do both clinical work as well as research work?
Yeah, so the Garvan and St Vincent's Hospital have created this entity, the Kinghorn Cancer Centre, which sort of spans across both the clinical and research space. And the idea of that institute is to further translational medicine. So we literally have the clinics on the bottom floors of this building and then the research on the top few floors of the building. And so people like me who literally work throughout the floors are really important in trying to bridge that gap between science and clinical medicine. So for me, I'm at the coalface treating these patients with cancer, and it's very obvious to me what the limitations of our current treatment strategies are. And I then have that privilege to be able to take that knowledge back to the lab. And so it's a two-way process. I can see the clinical problems that require improvement, but also when I'm talking to people in the lab, it's maybe more obvious to me what the clinical applications of certain research projects have. So I think it's really about bridging the gap and bringing science closer to patients and vice versa.
So taking that in mind, how does your week split itself? You spend a couple of days in the lab, a couple of days seeing patients. How do you manage that?
Yes, so it's supposed to be 50-50, but of course you can imagine things do sort of meld together. I have two very busy clinic days, so a Tuesday and a Friday. I'm basically in clinic all day, and that involves seeing patients, ward rounds, clinical meetings. And that will include treating patients, clinical trials, training, supervising students, all those normal things. And then Monday, Wednesday, and half of Thursday is research. I supervise biobanking projects. I do coding, so I am, one of those computer nerds looking at code. Lines of code on my computer. I'm occasionally in the lab. Fortunately, I have a really great wet lab team now to help me with most of that. So human ethics, it's a bit of a blur sometimes, but I generally spend those 2.5 days a week cracking on with my research.
Your patients must love you that you're in the lab as well. They'll probably want to know all the secrets.
They do, and that's interesting. Patients, I think, are much more aware of this stuff now. I mean, it's so easy for them to access information, and at Garvan, at the Kinghorn, we try and sort of get our research out there, but patients really are interested in this stuff, and they feel reassured that the doctors that are treating them have some research interests as well.
That's great. That's great. So let's just go back to the research side of the work you do, and head, neck, and lung. Why those areas?
Yeah, so they really have aligned with my clinical interests. So I started here as one of the main oncologists working in lung cancer and head and neck cancer. And it just so happened that at the time, one of the senior lab heads here also had interest in those two areas. And interestingly, in medical oncology, it's often those two that are paired together. And I really don't understand why. It's a very common pairing, actually. I think they have a lot of similarities. They have a lot of similar etiological factors, so smoking, age, primarily in men. So I have very similar patients across the board, actually. But the techniques that we're using in the single cell lab really have applications across all cancers. So the projects that I'm doing across both different types of cancers, although not the same, are similar. So I think that's sort of where I came from. And, once you get interested in things, you just keep going, I guess.
Yes. So let's talk a bit about the lung cancer piece. So obviously we know lung cancer is sadly one of the biggest killers in the world. How has your research evolved over time? What progress are you seeing?
Yeah, so I think the sort of genomic study of lung cancer has been an interest for me the entire way. And I guess the techniques that I've been using have been more refined, and we're really going down this sort of cellular sequencing platform now. And we've really been traditionally, or a few years ago, really looking at what makes cancer metastasize. And so that was some of the earlier work that we've done here. And now I'm really trying to look at how do we better personalize therapy for patients. So what's really hard for patients is knowing that there are some really marvelous therapies out there for lung cancer, but not understanding how that affects them as a person. And unfortunately, the thing that we do in the clinic is say, well, here, have some treatment and let's cross our fingers and see if it works. And that works out well for some patients and clearly not for others. So we really need more sophisticated techniques to try and predict which patients are going to respond to which therapies, and increasingly which patients are likely to get severe toxicities or side effects. So for me, understanding individual variation is important. So the variation between patients, but also the variation between cells, cancer cells and immune cells, and really trying to drill down into those, into that variability at a cellular level and how that impacts patient outcomes.
Yeah, look, it's really interesting. We had Kate Van Dyke last week talk about multiple myeloma, and she said exactly the same. So in her treatments, it is a bit of potluck as to how responsive the patients are and whether these drugs work. And then also a lot of her focus is on the toxicity or the adverse, very detrimental side effects that the drugs that they use have on the cancer patients too. We would have thought over time, you know, we've been researching cancer for years and years, why we wouldn't be better at being able to pinpoint what type of treatment or drugs would work better for certain individuals.
And I think that comes down to the limitations of the technology that we've had. I mean, when you look at how different the cancers are between patients, so when you can see the genetic differences between these cancers, you start to get an appreciation of why these treatments don't work better than they do. And then equally, now that we've got this cellular data, we can see that the cancer clones, so a clone of cancer are a group of cancer cells that are genetically similar. The differences between the clones in cancer can be quite marked, and their behavior can be quite different. And that's giving us now an appreciation. Why is it when you have a patient that responds to cancer and their cancer shrinks down, it doesn't shrink to zero? And that's because there's always a little clone left behind that's resistant. How powerful would it be to know what those clones looked like before you started treatment? Could you start layering treatment safely? So there are lots of unanswered questions, and it's clear when you look at how heterogeneous cancer is, why the treatments don't work better.
So specifically around lung cancer then, you know, it is one of the biggest killers in the world. Obviously, we know the smoking impact, but there are other factors as well. Can you just talk us through some of the reasoning why people do get lung cancer and why it's so hard to find a cure for it?
So very interesting you should say that, Nikki. So one of the projects we've been working hard on here is, why do patients who've never smoked get lung cancer? And these are a really interesting group of patients. They're becoming a higher proportion of patients with time, so they account for about 20%. And we've always said in the past, well, maybe they've had a passive smoking history, occupational history, whatever else. But I think those sorts of patients, the incidence is going down. As the incidence of smoking goes down, so does the incidence of passive smoking. And so we assume that it's something to do with our environment. So these patients have come in contact with something that, that has sparked the development of a cancer. And one of the hypotheses that we've been working through is those processes that we have in our cells to deal with that daily damage. I mean, we get daily damage to our cells from UV light, from, you know, all kinds of things, from the things we eat. But our bodies have a really efficient way of dealing with that damage and correcting genetic mistakes. Do we have a group of people in our society, and this just doesn't apply to lung cancer, but do we have a group of people in society who are just more vulnerable to these usual environmental factors? And we're trying to work with some of the resources we have here and working with a small group of patients we have with lung cancer who've never smoked to see if we can try and work out what those vulnerabilities are. And I think that's what is hard about lung cancer. We've got a group of patients who have no risk factors who develop lung cancer. And then we have a group of patients, even in heavy smokers, only 20% of those people develop a lung cancer. And why is that? It's probably something to do with the individual tolerance to damage to DNA. And I think the other thing to mention is that most people don't develop symptoms till they're really advanced. And that is why lung cancer is such a big killer. Often people present in the very late stages. So there is work being done on cancer screening, but unfortunately Australia is a bit behind Europe and America in that sense.
Yeah, and let's talk about that. I mean, probably 4 years ago, I was at the Sachs Institute, and they were talking about wanting to develop a national screening program here. And they had one of the forefront lung cancer researchers from the UK had come over, and now I think she was in her 70s, but she was very much talking about the incidence of smoking back then, and how you know, you were 72 times more likely to get cancer having smoked. But as you say, the incidence of that are now declining. What are the challenges of setting up a screening program and be able to look out for this across all of Australia?
Yeah, so there's been, I think, about now 4 international trials, so a very large American trial and a very large sort of multinational European trial, which did show that lung cancer screening improves cancer outcomes. So it shifts that dial towards an early diagnosis rather than a late diagnosis, meaning that people have an opportunity to have a curative surgery, for example. That is at the cost of finding lots of nodules in people's lungs that are not cancer. And there are some issues with that. And I think when that data was discussed here in Australia, they really felt that we needed local data to support a large program here. So there is an open study called the International Lung Screening Trial. It's being run here. I think there's a centre in Asia, but also in Canada, where the health system is quite similar. And it's a very similar design, but not exactly the same. So the patient population is slightly more refined, and they're also looking at some automated radiological indicators of people most likely to have a cancer found on these screening programs. So there was a press release, I believe, last year by the Australian government saying that this was a priority for them, but I do get the sense that they're waiting for the first round of data to come out of our Australian trial.
Okay, so for now, if you're sadly a lung cancer patient, what's the prognosis for those that have it?
It's hard because most people present in the late stages. So the majority of my patients will have either stage 3 or stage 4. So a stage 3 lung cancer is a cancer that started in the lung and has spread to the lymph nodes in the center of the chest. And then a stage 4 patient is one who has metastatic incurable disease. So in the stage 3 setting, if they have intensive treatment with chemotherapy and radiation, we know that about 30% of those patients are cured, meaning that 70% of them are not. And then in the stage 4 setting, most people, their prognosis is somewhere between 12 and 18 months, depending on how they respond to treatment. A stage 4 patient who does not have any treatment for whatever reason have usually passed away by 6 months.
That's very sudden, isn't it? After
pretty sobering.
Yeah.
It's pretty sobering. And when you compare it to other cancers, it's terrible. I mean, when you compare it to breast cancer, colorectal cancer, much worse outcomes.
And why do you think that's the case? Obviously, some cancers have, and their research has evolved significantly over time, and things like pancreatic cancer and lung cancer are really quite far down the food chain in research. Why do you think that is the case? Is it a lack of funding, a lack of interest?
So I think it's a lot of things, but I think that one of the things that's really struck me doing this now for as long as I've been doing it is that you don't get the same advocacy in lung cancer that you do in, say, breast cancer. And sadly, I think one of the main reasons for that is that people just don't survive long enough. So if you think about patients who advocate strongly for breast cancer patients, these are people who've moved through their disease and survived and have got the energy left to sort of fight for everybody else. Patients with lung cancer usually don't survive their illness, sadly. And so we don't have that community support. And then the follow on from that is not having that robust research or money and appetite for research. So that's really sad about lung cancer. Also, it just isn't as chemotherapy responsive as other diseases, sort of highlighting that we need different strategies. We need to do this differently.
Yeah. And is it the same prognosis for head and neck cancer as well, or do people that have that type of cancer fare a little better?
So head and neck cancer is a very broad group of cancers. I think as a single entity, they do also not do so well. Again, tend to be an underrepresented group of patients and can literally have no voice in some circumstances. So again, that same issue of having very poor amounts of advocacy. So your sort of standard patient with head and neck cancer, again, in the advanced stages, can have a very poor prognosis, yes.
Right, thank you. Now, let's move back to your kind of the genomic part of your research. And you mentioned in opening, you talked about protein. What is the role of protein in cancer?
Yeah, so proteins are like our building blocks, if you like, and they have many and diverse functions in a cell, in a normal cell and in an abnormal cell. And so when we study proteins in terms of cancer, there are many functions that interest us in terms of cancer research. The proteins that deal with repairing DNA damage, for example, we've talked about that. The proteins involved in cellular replication. So most cells in our body will divide and over the course of their lifetime. the proteins that might tell a cell to not replicate versus replicate, the proteins that allow cells to move around under certain circumstances. So there are so many proteins that are of interest to us, and also the proteins involved in an immune response, which is much more relevant to my lung cancer research, where we're looking at how cells respond to immune therapy. And there are lots of things that happen in that interaction between a cancer cell and an immune cell, which involve lots of protein and communication, if you like, between cells.
So the piece on immunotherapy, again, like genomics, it's quite new in the scientific world, but it seems to be having some fantastic results. Could you talk a bit more about immunotherapy and the impact it's having?
Yeah, so the immune therapies are essentially medications we give that stimulate our own immune system. And so a way of thinking about it is a cancer cell is abnormal. It's not a normal cell. And under normal circumstances, your immune system should detect that that cell is abnormal and get rid of it. And in fact, in the lab, when we're trying to give cancer to mice, normal mice will just reject any cancer that we inject into them. And we have to quite severely immunocompromise a mouse in order to give it cancer cells to do experiments with. And so what we think happens in people where a cancer takes hold is that the immune system has probably been controlling this cancer for some time, but then the cancer evolves and changes and gets really good at turning off those normal immune reactions that should happen. And so the immune system becomes sort of tolerant, for want of a better word, of this cancer that starts to flourish in the body. So these immune therapies are designed to reinvigorate those normal responses and to start allowing the immune system to do its job and kill the cancer. And in lung cancer, they have been incredibly successful. So there are a group of patients in lung cancer who have lung cancer who respond very well to these immune therapies. What's sad about this is that it doesn't apply to everybody. And we have some fairly crude markers that we use to try and predict which patients will respond, but they're not perfect. They're far from perfect.
And when you talk about markers, what do you mean? Can you explain a bit more about that?
Yeah, so what we would love to have, the ideal thing we would love to have is some sort of indicator, either in the tumor or in the patient, maybe a blood test or something that we see looking down the microscope that says, okay, treatment A is for you and treatment B is not. And so one of the markers we have is we take a little tiny slice of the cancer tissue and put it on a slide, and we put a dye over it looking for a certain receptor on the cancer cell, and it's called PD-L1. And if tumors that have a lot of this receptor tend to do better with these immune therapies. But again, it's not a perfect marker.
Thank you. So obviously you're looking at the whole genomics piece now. You're talking about proteins. A lot of the other researchers have talked about the importance of metals and over growth of metals, for example, copper in tumours. In regards to your areas, lung cancer and brain, do you have that issue as well? Are you dealing with metals, or is it purely looking at the proteins?
Yeah, no, that's not a focus of what we're doing, Nikki. We are mainly dealing with the genomics and the proteins at the moment. And looks, I've seen some of that work and it's fascinating, but it's not something that we're looking at.
Lovely. And the work that you are doing, what benefits will it have for other cancer research? How does it grow throughout the cancer research sphere?
So, I mean, with immune therapy particularly, is now being used in almost every solid malignancy. There are very few solid cancers which don't use immune therapy in some respects. And in all of those subtypes, running up against exactly the same problem. Who do we use these for? How do we know if it's working? And how can we better predict side effects and toxicity? So all this work that we're doing to try and help with predicting success in treating these patients will be applicable sort of across the board. And similarly, looking at, why patients develop cancer, why patients who've never smoked develop a lung cancer, I think is going to give us real insights into what happens along that journey between a normal cell and an abnormal cell, and may give us some really important ideas that will be applicable to other cancers as well.
Yeah, that's great. Thank you. I've had a question here about a combination of immunotherapy and chemotherapy. Do you treat patients with both? And if so, how do you counteract the impact of chemotherapy on the immune system?
It's really interesting because I got asked to give a talk on exactly this to our national meeting. I think it was the end of last year. And when they gave me the talk, I thought, hardest topic ever, especially to an oncologist, because chemotherapy is our bread and butter. But when I looked at I actually went back to some of the really old studies looking at chemotherapy and the effects that chemotherapy has on the immune environment. So you have to remember that a cancer is a small mini, I don't know, like a mini city, if you like, and it has lots and lots of interactions going on. And so we know that immune therapy stimulates the immune cells, but traditionally we've always thought of chemotherapy as being an immune suppressor. But it's not so simple. And we do know that in some circumstances, when you give chemotherapy, you can, in some respects, prime that immune system to be more sensitive to the immune therapy. Now, the trials that have been done have been not really done with that in mind. I mean, the way oncologists think is if one therapy works, will two be better? And if two works, will three be better? And so the way that the trials have been designed is taking chemotherapy, which we knew worked a little bit, and then adding immune therapy on top. But I think as we move forward, there will be an opportunity to use these treatments in a much more rational manner and say, okay, this particular chemotherapy drug is likely to have an effect on this particular immune cell, which is going to then help immune therapy work better. And what we may end up doing is moving away from doses of chemotherapy, which are really there to kill cancer cells, but maybe dialing the dose back and saying, okay, the aim here is to prime the system and then hit it with immune therapy. So I think moving forward, it's actually going to be quite an exciting field to work out how can we deliver it more effectively.
Yeah, fantastic. Thank you. So going back to your piece on how you can use immunotherapy and your studies across different cancer types, I mean, what is your hope for the future? You're doing this research now. In 5 years, where do you hope to be in that piece of research?
So I really think that cellular genomics and cellular sequencing has a lot to offer the clinic, and there are a lot of barriers to that at the moment, but they are similar barriers to what we had 10 years ago when we were talking about sort of standard genetic tests, which are in the clinic now. They get done routinely for most patients. And what I hope is if we can actually find some cellular indications, cancer indications, which are going to be able to tell clinicians what the best thing is to do for the patient. And we'll be able to then, rather than say, this is what we have, let's see if it works, we can say, here's a menu based on your results, this is what I recommend, and I think it's highly likely to be effective. So you can imagine how much easier it would be for patients to make decisions on their own behalf, and also much better to avoid side effects and avoid giving patients therapies that just don't work. So my hope will be that this research allows that to happen in the next 5 years.
Yeah, that would be wonderful. And you talked about the side effects. Can you just expand on that a bit more? What are the challenges people have at the moment going through that treatment?
So when you stimulate the immune system, the side effects you get are from an overactive immune system. And fortunately for most patients, those sorts of side effects are relatively mild. They might be sort of like an eczema type rash. They might be some thyroid problems, which are easier to manage. But now that these medications are being used much more widely, I'm starting to see the weird and wonderful. And sort of one end of the spectrum is a patient that I have who's been off immune therapy for nearly a year, but is still experiencing very severe side effects. And so for some people, this immune cell stimulation is extreme, and they get much more immune activity than they need. And so the hard thing about immune therapy side effects is they can be very out of the blue. So I've had some people who've had a side effect after one dose. I've had another person who's been on treatment for 5 years and has only got their first side effect after 5 years. So our understanding of what actually happens in any given patient is quite I think at a basic level at the moment, we certainly have no way of predicting what will happen. And now also increasingly getting patients where the side effects are hard to treat. So it's very hard for patients, especially if they've done very well for their cancer management and then are stuck with these debilitating side effects.
And do you see similar side effects with a similar group of people, or likewise similar responsiveness to drug treatment? Is it, versus sex or your ethnic makeup? How are there groupings that you can identify and say this person is X and they'll probably be treated with this drug because of their genetics?
So the short answer is no. So we have a few subtypes of lung cancer that we know about that have very specific treatments, and they account for a really small number of patients. So there are a group of patients that can be treated with tablets for lung cancer, but they only account for about 5% of all diagnoses. In terms of looking at which patients might get a side effect, was that also part of your question, Nikki? Yes. So we know that most of the research has been done backwards and sort of saying, so people who've had a side effect, looking back, what was that all about? We know people who have autoimmune disease already, okay, so people who already have a diagnosis of something like rheumatoid arthritis, for example, they have about a 30% chance of having a flare of that disease if they have immune therapy. We know that people who have an immune-related side effect are also more likely to have the good effects, so that they're more likely to have control or shrinkage of their tumour. What we don't know is sort of at baseline, which patients are going to have a side effect. So it is really, really hard.
And then in regards to responsiveness to the drugs you're giving them, are you finding sometimes people can respond almost immediately, and then other subgroups take several doses? What's the challenge there?
So typically we would give someone about 9 weeks of treatment before we did a first scan, and the reason for that has been that when you're stimulating the immune system, you have a cancer like this, and then when the immune cells rush in on a scan, this looks bigger. So if you do a scan too early, you can see what looks like the cancer growing, but actually is just the immune cell swelling the tumor. And so if you wait that 9 weeks, you're more likely to see a response. So we normally wait about 9 weeks. Having said that, I have had patients where I've only delivered 1 dose and had to stop because of side effects, and that I've got one patient in mind had a response to treatment for over a year. So it is, everybody is different.
Thank you. Just a reminder, we've got about 5 to 10 minutes if anyone has any other further questions. Let's move on to something completely different now, funding. We know why we're here, and everyone on the call knows, but could you just, in your words, explain to our staff and our board members the importance of early career funding and why it's been so critical to you?
I mean, I think, the funding environment is just really difficult for early career researchers. And I think it makes it also really hard for us to go out on our own and to explore our own ideas. And so for me, I've moved from pancreas cancer to lung cancer, and without something like Cure Cancer, I'd have never been able to establish a track record for government, for government funding. And I would have had to just stay researching pancreas cancer forever. So I think it's really nice to be able to have an idea as a postdoctoral research officer and actually work it up on my own. And I think it gives us independence. It allows us to work through our ideas, and it allows us to diverge from our supervisors or our, senior researchers. And I think that's really valuable. Otherwise, you just get the same thing over and over. So for me, it's been very, very important. And it's not only been just important for me, but allowing me to set up a program of work here at my institution, which didn't really exist before.
No, that's great. Thank you. I've got another question here about funding, and in regards to, do you find the stigma of smoking has had an impact on lung cancer funding?
I think it probably does. And I think it's probably hard for patients as well, because they feel like they did it to themselves. And so there isn't that same sense of outrage that other people with cancer get. Why did this happen to me, and why are things not better? Why is there not more treatments? Because they feel like they were sort of partly responsible for developing cancer. So stigma is a really big problem. I think it leads to delayed diagnosis. We know that patients who continue to smoke during their treatment don't do as well. And I think, that sort of sense of shame really harms patients. But, I do wonder if that's also part of why people don't contribute to research more.
Yeah, thank you. And then talking about you and what drives you, what's most rewarding in your role, both as a researcher and a clinician?
I love being a clinician, and I love what I do, but it's not hard in my line of work to see the limitations of what we have. So it is a real privilege to be able to come up here and try and do something about it. So I think the most rewarding thing for me is the idea that maybe something I do is going to help people in some small way. And that might be a new approach, a new treatment. It could be a very minute amount of help, but knowing that potentially the field will be left changed by me in some small way. And I think that gives me hope, but I think it also gives my patients hope, which is important to me.
Yeah, thank you. And then, in the future, you've talked about research going out globally. Can you talk about the collaborations that you do? Do you work with other units in other countries at the moment on your research?
Yeah, so we've got a couple of collaborations that are here in Sydney, and I guess one of the more important ones is with the Clinical Trials Centre here in Sydney and a project called Enrich, which is really looking at mapping the patterns of care of lung cancer in New South Wales, both metropolitan and urban, and creating a big biobank ready for researchers to use. And so I've been involved in that project since its inception, and I think it's one of the biggest projects in lung cancer of its kind. And I think will be really helpful in just creating those building blocks. We've also got some other collaborations with the other big lung cancer units here, Royal North Shore Hospital, for example. So those have been pivotal in my research, because one of the issues with lung cancer is getting your hands on samples. So blood, tissue, data, that's all very hard in lung cancer.
Yeah, okay. Absolutely understandable. Bit of a controversial question here. Given that pancreatic cancer survival is also so low, why did you decide to move away from that type of research?
Look, part of it was just what happened. So I had always been interested in lung cancer as a clinician, but when I started here at St. Vincent's, they really needed someone to work in lung cancer. And so that's what I did, and I was very happy to do that. And somehow the moons aligned, because then there was someone here looking for a postdoc in their lung cancer lab. So, it's just where the wind took me, Nikki.
But that's a fair enough answer, isn't it? Absolutely. And then finally, just about your team and the units there. Can you just talk a bit about the structure? You're talking about setting up a biobank. So what does it look like at the Garvan, and how do you carry out your research?
So yes, so Joseph Powell is my group leader. He's the lab head for the cellular genomics lab. So we have a large lab up on level 7, which consists of research assistants. I have a biobanking manager who does all my biobanking. And then I've got this sort of pod of postdocs with many computer screens and sadly a lot of mess at my desk. So we've got biobanking in lung cancer. We've got a large blood biobank that's recruiting over 130 patients. We've got now a biopsy biobank that's going to be pulling in tissue for all cancer types. And so that's sort of level 11 and level 10, and then down on level 5 at the clinics, clinical trials, patients, and then the hospital is in a separate building. So I've got sort of 2 research assistants dedicated to my work, and most of their work is dealing with patient samples, which of course is a fairly delicate operation. And then I have some other sort of computational postdocs that help me with some of my work on the genomic stuff.
no, it's great. It's all in one building as well, isn't it? You just
Yeah, it's lovely.
And then finally, before we summarize, what can we do to help? How can we here at Cure Cancer support you more?
So, I mean, this funding has been really amazing. And I think shedding light on some of these less well-funded cancers is really important, and especially those groups of patients that just don't have those same advocacy groups. I mean, pancreas cancer would be one of them, lung cancer, cancers of the head and neck. These people just quite literally cannot help themselves. And as I said, in head and neck cancer, sometimes quite literally don't have a voice. So allowing people like me to do interesting and novel things, and for you to shed light on these cancers, to sort of generate public interest, is incredibly important, because I firmly believe that, you know, if you build it, they will come. And so trying to build these programs for these under-resourced cancers is when we're going to get change.
Lovely. Well, thank you. Thank you for your time. Just to recap on a couple of points that you mentioned. So at the moment, 20% of lung cancer patients have never smoked, which is phenomenally high. We don't currently have a clinical trial for lung cancer, but obviously something that we hope for in the future. If sadly you don't have treatment, you've probably got about 6 months if you have lung cancer, which is just terrible, isn't it? Similar prognosis for those with the various head and neck cancers too. And then really just touching on how important immunotherapy and genomics is in discovering what the right type of treatment is for the different patients as well, because at the moment, as you've said, it's a little challenging for some are much more responsive than others, unfortunately, in this day and age. Well, thank you for your time. We really do appreciate it. It's, you know, you're part of our family. We've supported you for a couple of years now. We've done a lab tour there, but obviously once we're all ready to go again, we'd love to bring some of our doctors around and you can show them the wonderful work you're doing. Thank you to everyone that has attended as well. We hope to see you next week, which we will be talking to Dr. Orazio Vittorio and his work on childhood brain cancer as well. So for now, thanks for your time. Have a good day, Vanessa.
Thanks, everybody.
Thank you. Bye-bye.